My talk was discussing resistance to BTK inhibitors in CLL, and as we know, with longer follow-up with ibrutinib and now even some follow-up with acalabrutinib, there are patients who do progress, especially those who are being treated in the relapsed and refractory setting. We've shown previously and kind of validated, as well as a number of other groups, that there are a number of factors that contribute to patients who will develop resistance on BTK inhibitors. Probably the most important ones that we've seen so far are patients who at baseline have a complex karyotype, which is 3 or more cytogenetic abnormalities. People with CLL progression are also very likely to have dysfunction in TP53, either deletion 17p or a TP53 mutation. We've seen in our cohort, younger age is also associated with patients progressing with CLL. And then there are patients who progress with Richter's transformation, and in those patients we see abnormalities in MYC as another predictive factor. So unfortunately, patients who relapse after BTK inhibitors tend to have a fairly poor progression-free survival and overall survival, although that has gotten a lot better in the past few years with the introduction of venetoclax for this patient population. However, we still have a lot of work that needs to be done for this group of patients, and there are a number of targets that are currently being evaluated in both preclinical settings and now in clinical trials. One method would be reversible inhibition of BTK, so there's a number of molecules that have been developed for the purpose of inhibiting BTK in the presence of the C41S mutation. There's two of those that have clinical trial data that has already been presented and is looking fairly promising. Those are ARQ-531 and vecabrutinib. And then there's a couple of other molecules that are in clinical trials, but we don't yet have data on them. Other potential ways that we can overcome resistance to ibrutinib, there's some data with selinexor, which is an exportin-1 inhibitor. BRD4 inhibitors are looking very promising in vitro. PKC beta inhibitors also looking very promising in vitro. So there's a lot of different avenues that we can explore, and hopefully with some more clinical trials and even potentially exploring combinations in this group of patients, we'll see even improved overall survival. So next steps after the meeting, in terms of what we're doing at our institution, we're continuing to look at our patients, large cohort of patients who were treated with ibrutinib, now a large cohort treated with acalabrutinib, and do some more sophisticated genomic work to try to even further identify those patients who are likely to have fairly short remissions versus those that are likely to have very, very long remission durations and probably can be treated just fine with a single agent BTK inhibitor, whereas those who would be predicted to have earlier remissions, those might be better candidates for combination therapies or other approaches. As well, we're working on clinical trials with some of these novel agents, some of the things that we and others have worked with in the laboratory, and then continuing preclinical work with some other directions.